Hello, everyone, and good afternoon, and welcome to Breakout Session 2A, Kentucky's Response to the Opioid Epidemic. I'm Jana Collins, and I will be serving as the moderator for this session. A few notes before we get started. We will try to reserve the final 10 to 15 minutes of the session for Q&A. As you have questions during the presentation, please enter them into the chat box, and I will monitor those questions during the presentation, and will facilitate the Q&A session at the end of the presentation. Recordings of this session will be available roughly 6 to 8 weeks after the conclusion of the summit. So let's get started. It is my pleasure to introduce our speaker for this session. Van Ingram is the Executive Director for the Kentucky Office of Drug Control Policy. Van joined ODCP in November 2004, shortly after it was created, with the mission of coordinating Kentucky's substance abuse efforts in enforcement, treatment, and prevention education. Van served with the Maysville, Kentucky Police Department for more than 23 years, the last 6 as the Chief of Police. He is a former president of the Kentucky Association of Chiefs of Police and was named Kentucky's Chief of the Year in 2001. He is a former recipient of the Governor's Award for Outstanding Contribution to Law Enforcement, as well as the Melvin Shine Award for Distinguished Service to Kentucky Law Enforcement. Van is a certified law enforcement instructor and has trained officers across the state on a variety of topics, including community-oriented policing, case management, and Kentucky's substance abuse issues for chiefs, sheriffs, and command staff. He is a frequent speaker on a variety of substance abuse issues, both in Kentucky and nationally. Mr. Ingram, I will now turn it over to you to present Kentucky's response to the opioid epidemic.
Thank you, Jana. It's great to be with you all this afternoon. I wish we were in person. You know, it's always good to get that feedback from the audience and see people nodding their heads and agreeing. So if it's okay with you, I'm just going to pretend that you agree with everything that I say and that you're back there shaking, nodding in agreement. Let me start out by saying how proud I am of our harm reduction community in Kentucky, and how proud I am of our public health workers who operate our syringe service programs. Look, with 2015, we fought hard to get this law passed. And it wasn't easy. We barely got it over the finish line with just a few votes that we needed to clear the committee. But I knew the way it was passed, the real work was just beginning. Our local public health officials were going to have to carry the lion's share of this load to convince their communities, to convince their city councils, their mayors, their judge executives, their county commissioners that harm reduction is the right thing to do. That in the spirit of Matthew 25, what we've done for the least of these, my brother, you've done also to me. And that's what needed to happen. And that's happened in 82 Kentucky communities. And I got to tell you guys, I have traveled all over the country and Zoomed all over the country telling that story. Other states and other communities can't believe what we've done here in Kentucky. I think what they're kind of saying is, how can you backward folks get all this done? But I'm always proud to go tell the story of what public health in Kentucky has done, and what they continue to do, and what we're going to continue to do even more. So I'm going to try to share my screen here. You think after all these years of doing this, we'd get pretty good at it, but I still struggle. Hang on one second here. All right, I think we got it.
Looks good.
So yeah, we're going to talk a little bit about Kentucky's response to the opioid epidemic, Kentucky strategy, what we're working on, and what we're thinking about for the future. So as the opioid epidemic raged on, many of you remember 2010, 2009, 2011, we had 76, 77 pain clinics in Kentucky. Only about half of them were physician owned. It had become an entrepreneurial business to, in a strip mall center or a trailer, to open up a pain clinic and find a doc over Craigslist that would come into your community for 2 days a week and write the heck out of pain pills. What House Bill 1 did in 2012, we really tried to set some parameters about prescribing opioids for chronic pain. That needed to be a very thoughtful, deliberate decision made between a practitioner and a patient. And until that time, it had been a very casual decision. Oh, you're in pain? Here's have some Lortab. And we saw where that got us. That was causing havoc. So we faced a lot of opposition from the medical community on this bill, but it did what it was supposed to do. It really closed the funnel and slowed down the prescribing of prescription opioids significantly. And that has been good. We came back in Senate in 2015 with Senate Bill 192. The first bill, House Bill 1, they called that the pill mill bill. Then in 2015, they called it the heroin bill. And it increased some penalties for heroin. It created a new offense of importing heroin into the state. But really, this basically was more of a harm reduction bill than anything else. This is the bill that set up the Good Samaritan provision, where if you're using drugs with someone and they suffer a fatal or suffer an overdose, if you call 911 and stay with them, if you have a small amount of drugs or paraphernalia, you're not supposed to be arrested in that situation. It also set up the very liberal prescribing of naloxone and made it really clear that there didn't have to be that practitioner-patient relationship to get naloxone out in the community. But the main thing it did is what we're talking about today was the syringe service programs and created a path forward for that. I will tell you that when we walked out of the conference committee with the idea that you had to get permission from your city and county government, I really thought Lexington, Louisville, maybe one or two other places. I never dreamed we'd be where we are. I'm so thrilled to have been wrong about that. Then we came back in 2017 with House Bill 333, limited acute prescribing to 3 days worth, except in certain situations. I think we still got some work to do on that one. I think there's still some folks that are ignoring that one. But we're working hard with some opioid stewardship programs to address that. I want to stop a minute to talk about fentanyl before we go any further. I want you to understand this. In 2018, we dropped fatal overdoses 15%. For the first half of 2019, we were doing very well. And then the second half of 2019 was the fentanyl explosion. And it started being seen everywhere. Fast forward to 2020, fentanyl continues to be the business model for our cartels. And we get hit with COVID, and people are isolated and they're alone and they're out of their comfort zone and they're afraid of losing their jobs, and so much is going on. So many people return to use. Well, when there's so much fentanyl in the drug supply, a one-time return to use can be the last time. And we saw that a lot. But it's not going anywhere, folks. For $15,000 to $20,000, you can buy a kilo of pure fentanyl. If you buy a pill press, you can find one on eBay for $1,000. You can produce about 750,000 to 100,000 1 to 1.5 milligram pills. At $10 to $15 per pill, for that initial investment of $20,000, you can make between $750,000 and $1 million return on investment. That's not going anywhere. This is way too lucrative. And then think about it logistically, okay? The cartels have to move a lot of drugs across borders and all across this country. Because fentanyl is 10 times more potent than heroin, what used to take me 10 pounds, I can now do in 1. Logistically, how much easier is it to move something that's 1/10 the size that it used to be? For the first time in 2021, fatal drug overdoses became the #1 cause of death for folks between 18 and 45 years old. Not vehicle collisions, not anything else, but fatal drug overdoses. It was a devastating year for us. Kentucky, 2,255 deaths. That's the equivalent of 6 people every day. That's why the work you do is so important. And I pray you keep doing it every day, because Kentucky really needs you out there doing what you're doing. We've tried to, a lot of our strategy now has been to try to remove as many barriers as we can to success. we've got a pretty good treatment system in place. Because of our expanded Medicaid benefit, and we've got a very robust benefit within Medicaid for substance use disorder. We've seen just a major increase in the amount of providers in Kentucky and the amount of providers that will take Medicaid managed care. And in a lot of situations, we can get people in care the same day. Many of you who have been around a while like me remember when there used to be 4 to 6 week waiting lists to get into a program. And that was totally ineffective. The person that wakes up with a substance use disorder this morning and says, I can't live this way anymore, the addicted brain will change their mind before the day's up and say, oh, you're okay, you're good, we're good, we'll be all right. So it's so important that we're able to give people help the second they realize that. And one of the best ways to do that is 8338-KY-HELP. If you don't have that number memorized, please write it down. If you don't have it on a poster in your syringe service program, please contact me and we'll get you on. That helpline is run by Operation Unite from this office. We pay to run that. It's staffed with mostly social workers that do a very good job. We average about 300 to 350 calls a month in calls, but then we make about 1,000 outgoing calls as follow-up to people who've called before. We've got a lot of folks in treatment, but the thing was, we promoted this in the past, but you've got to continue to promote it all the time. And I don't have the money to continually have it on TV and on the radio and on billboards. So any way you can help me promote this in your community, I want to make sure our police officers know that number and know it as a referral number, that our medical community knows it, that our public health knows it, that our jails know it. Anybody who has a touch point with someone with an SUD, I hope you know that number. The other tool is findhelpnowky.org. This was developed by the Kentucky Injury Prevention Research Center at UK, created on a grant from CDC that we're very grateful for. And really, this is the hotel tonight of treatment. You can go in there and with a few clicks of a mouse and type in a very little information, and you can find out what's available. It's kept up every day. So if it's a residential program, you'll know if they have availability. They have a great staff that works on this and promotes it and keeps it fresh. Websites aren't any good if they're not kept fresh. We've all seen those websites that were created as a substance use disorder locator, and in 2 years, they're completely useless. This is kept up with all the time. There again, when people have that aha moment, I want to be able to know where to go, and findhelpnowky.org is a great resource for that. We've centralized naloxone distribution, but I buy naloxone for law enforcement with dollars from this office. Our public health folks help provide naloxone to a lot of your SSPs. Behavioral health has grant money through the core program that helps distribute naloxone. Our public health folks that go out in the trailer and set up at fairs and Walmart parking lots and all that Narcan comes out of a partnership with the Kentucky Pharmacists Association. So we can very easily keep track of where it all goes. Before it was all disjointed, but now everything rolls through them. And that gives us a much better idea of where we're sending naloxone and where we may need to send more. So we're very proud of that partnership. As you can see, in fiscal year 21, over 50,000 dosage units were dispensed, and we need another. We need to double that. Some of the major treatment projects that did go on, and these are combination projects between the Kentucky Opioid Response Effort, Dr. Katie Marks' program, and the team over at the Division of Behavioral Health, Commissioner Morris's group, as well as my office. But we have a treatment stipend program in fiscal year 21. We use that to keep 12,477 individuals in treatment a little bit longer than maybe that the managed care would pay for. Because we know the more residential days we can get, the better our odds increase of success. We work to expand the use of medications, use disorder medications to FQHCs around the state, trying to keep more people, responsible people, involved in prescribing of buprenorphine. We've offered free data waiver trainings. We've set up bridge clinics at University of Kentucky, University of Louisville, St. Elizabeth, and Appalachian Regional Healthcare. What I mean by a bridge clinic is when people come into the emergency department with a non-fatal overdose, we want to serve as a bridge to get them on buprenorphine until such time as they can find a permanent treatment program of their choosing, whether that be on bupe or whether that be abstinence or whether that be Vivitrol, whatever the person feels like gives them the best chance for success. We have about a dozen quick response teams around the state. Some of them are staffed with law enforcement, some of them staffed with EMS, some of them staffed with public health workers, some of them with a combination of those three. They go out after a non-fatal overdose within 72 hours, try to make contact with that person, just to let them know help is available should they want to avail themselves of it. We have worked to file an 1115 waiver with Medicaid. And what this waiver says is we're asking to be paid to do substance abuse treatment services behind the walls of our prison and the jails that we provide services already in. This will be a game changer if we get this passed. A lot of other states are looking at this, see whether or not we get it passed. But we want to be able to provide as much services for SUD as we can while people are in our care at the Department of Corrections and while they're in the care of 23 or 24 local jails where we have programs going now. Our KSP Angel program that allows people to come to a KSP post and say, I need help. And our KSP folks will make the arrangements to find them a program and help them get in there. Over 200 people have availed themselves of that program in the last couple of years and walked in the door of a KSP post and said, I need help. We've done Casey's Law trainings around the state, and we have some more of those coming up. So folks can understand what is at stake and how to work through the Casey's Law process when the loved one has an SUD and you're trying to get help for them. We continue to work to expand syringe service programs. We have 82 of them. That's not enough. We need more. Many of you may know the story of the 220 counties identified by CDC as vulnerable to a rapid HIV outbreak. And we had over 50 of those counties in Kentucky, and I think it was 54. And still, not all of those counties have an SSP. My God, if you've been identified by the CDC as being a county for a rapid HIV outbreak, you need an SSP. That just, there's no ifs, ands, or buts about it. So we got work to do yet. CORE has, our Kentucky Opioid Response Effort has sponsored CORE 12 trainings around the state. This is a Hazleton Betty Ford training that really tries to teach providers to do patient-led treatment. And what we find is about a third of the patients choose an abstinence-based model. About a third will choose a buprenorphine and about or methadone, and about a third will choose Vivitrol or naltrexone. And we've seen that hold true in a prison and jail program as well. Giving people the choice, that's how it kind of breaks down. And people should have a choice in their training or in their treatment. I'm sorry. We've worked with the Kentucky Judges College with a program called Restore, trying to do treatment for or training about SUD treatment for criminal justice folks. Chief Justice Menton, who's retiring later this year, has been a real champion of this effort, believes strongly in SUD treatment within the criminal justice field, and has been a big proponent of this program. We've been offering trainings on this American Society of Addiction Medicine and their ASAM scores, how to create those and how to use that system. I talked at the beginning of how we're trying to remove barriers to success. Well, one of the big things that keep people in recovery from succeeding is not being able to find meaningful employment. And so we've addressed that in a number of ways. And one way we've addressed it is what we call SITE, the Strategic Initiative for Transformational Employment. That's a program that is partly funded by the Kentucky Opioid Response Effort and partly funded by my office. We have partnered with Eastern Kentucky Concentrated Employment Program, or EKCEP, and we've asked them to place in all the vocational centers, career centers around the state. I think there's 12 of them. We want somebody whose main job, their only job, is to help people in recovery find meaningful employment. So they might spend part of their time out trying to recruit employers to hire folks in recovery, and the other time they may spend visiting treatment centers and getting the word out to folks in recovery. Come to me and I'll help you find a job. We do more than that though. We have career coaches beyond once a job is found. We have people hired that are career coaches. They're going to pick up the phone and say, do you have the clothes you need for this job? Do you have the tools you need for this job? Do you have the transportation you need for this job? And if something comes up and you need help, call me. We want to remove those barriers that keep people from succeeding. And if I can get somebody a pair of work boots and that helps them succeed, then that's what I want to do. If somebody needs some dress clothes, then that's what I want to do. So many of these folks have very little and have been through a lot of trauma in their lives and need a helping hand. And so however we can do that, we want to do that. I've also partnered with the Kentucky Chamber Foundation. I've collected a government paycheck since I was 19 years old. I've been a dispatcher, I've been a jailer, I've been a police officer 3 weeks after I turned 21. And then after 24 years of policing, I came here for the last 18 years. And I know what you're thinking, how can a guy in his late 40s work all that many years? But trust me, the math works. So I have no credibility in the private sector community. I can't go to the private sector and say, here's what you should do. Because I've not run a business. I've not worked, that's not where my background is. But the chamber, on the other hand, has a lot of street cred when it comes to employers, large and small. So I've partnered with the chamber to hire some folks to go out and do trainings for employers on why they should take a chance on people in recovery, take a chance on people that may have a felony on their record. That we've got to increase this labor pool in Kentucky. And oftentimes I hear from employers that my people that are in recovery are the most loyal, dedicated people I have because they're so grateful to have a job. Many of them have been, as I say, to the gates of hell and back, and they're so grateful not to be back. So Chamber goes out and does a lot of training. That we just had our first, what we call a fair chance employment school, which was 3 days of training for HR directors about how to run these kind of programs. And we had tried to get 10 companies. We had 30 apply. We ended up taking 15, and those 15 represented over 20,000 employees. So we had some major employers in there, and we're really working hard to make sure that people who want a job can get a job. In the same vein, we started out with 5, and the program went so well, we're now up to 10 or more Department of Corrections probation and parole officers that we sent to training to become employment specialists, hiring specialists. They work with probation and parolees. There again, one of the best barriers to success is employment, and that goes the same for our criminal justice involved folks, probably even more so. So this program is pretty much statewide, and it has helped a lot of people in jobs. On that site program, you see the statistics there. In fiscal year 21, we worked with 2,576 people that got them in jobs through that program. One of the other issues that get in folks' way when they're trying to stay in recovery is housing. If you live in a house where other people are using, if you live in a neighborhood where all your friends used to be and they're all using, when you go home to a holler where this is going on, or an apartment building where use of illicit substances is the norm, what's your success going to be when you come out of treatment? When you're really vulnerable in that early recovery stage and everybody around you is using. So we've offered up some grants for transitional housing. that are MOUD supportive. So if someone is, so many of the houses in Kentucky and across the country won't let someone with buprenorphine or methadone live there. So we put some grant money out there to encourage that. We've also given some money for the Oxford House model. Oxford House is a long-standing, nationwide, a very respected model for housing for folks in early recovery. And we support that model, and it supported its expansion. I give out grants to our community mental health centers every year, and we really encourage them, and a number of them have opened up sober living or transitional housing homes through that grant process. Same way my office gives money to NAS, no abstinence syndrome for programs to take care of moms and parenting and pregnant women. And we want to keep those people longer as postpartum. So I've given some grants to support that. So we can keep them in the supportive program more than 6 weeks after delivery. Keep them there a few months, keep them there till they can get a job and get on their feet. We've worked to increase the number of peer supports, people with lived experience, people who have recovered themselves. I don't care what your profession is or what your situation is. Cops talk to other cops, lawyers talk to other lawyers, nurses talk to other nurses, and people who've been in addiction probably are not going to listen to me as much as they're going to listen to somebody who's been there and knows that disease, knows that process, and has improved their life. So we really believe in peer supports. We believe in the work that they can do. I know most of you that have student service programs in Kentucky have affiliation with peer supports, and we appreciate that. I think it's so important. It's a proven way to help people get into a treatment program. Talking about barriers, one of the other barriers that we've learned about is transportation. A great many probation and parole officers told me that a lot of times success on their folks is because of a lack of transportation. Can't get to a treatment appointment, can't get to a job appointment, can't get to a required visit. So I set up a $1.9 million transportation pilot project where we use the same folks that do non-emergency medical transport for Medicaid. We have them in every community. And we use them to haul around people who are criminal justice involved. They mostly need to get to a treatment outpatient program or a residential program. We've opened it up to allow our alternative social workers at DPA to also use this program. It's not Uber. You can't call and get a ride in the next 20 minutes. You have to apply yourself and schedule it a couple of days ahead of time. But it does work, and it does get people where they need to go. And we hope it proves to have good outcomes. The Kentucky Opioid Response Effort, Dr. Marks' dollars has got prevention back into over 200 schools with Too Good for Drugs. Evidence-based program is proven to be very successful in the past. And we are proud that we're able to pay for that curriculum for any school system that wants it. Sources of Strength, another great program, not especially SUD specific, but a really good character program that's evidence-based, and it's been proven very successful as well. Along the same lines of prevention is this opioid stewardship. And Dr. Marks and her team have worked very closely with the Kentucky Hospital Association to make sure our hospitals are practicing opioid stewardship and are aware of how opioids are being prescribed in their facilities, and more importantly, as people leave their facilities, and try to keep an eye on that. I want to talk about a couple of other things that are going on. So a couple of years ago, the General Assembly passed a bill called Recovery Ready Communities that the governor signed into law. That program will be kicking off very soon. What this does, right now, some communities have what's called work ready communities. Some are safe community, have a designation as being a safe community. this recovery ready community, Representative Adam Bowling sponsored this. And what we're doing is setting up the things a community should have to say they're recovery friendly, that they're recovery ready. So do you have fair chance employment in your community? Do you have transitional housing in your community? Have you checked or looked into the transportation needs in your community and addressed that? Those kind of, do you have AA? Do you have Celebrate Recovery meetings? The things that people, and then on the prevention side, does your law enforcement carry Narcan? Do you have Too Good for Drugs in your schools? Do you have any other kind of prevention programs in your communities? And what we'll probably do is, I partnered with Volunteers of America Mid-States to help me run this program. And it's complicated because you can't expect Berea to have what Lexington has. And you can't expect Flemingsburg maybe to have as much as Berea has. So we're going to have to weight it based on the size of your community. What are the things you have to have and what are the nice to haves? But we're looking forward to that. We plan to have a first draft done at the end of September. And we're hopeful to start the program fully up and running by January 2023. I've got a great advisory council that was appointed by statute, and they're going to help shape this. And there's a lot of stakeholders and a lot of really smart people on that advisory council, and we look forward to their input. This is such a big deal. It takes a lot of minds and a lot of brainstorming and a lot of input to get it right. And that's the most important thing to me, that we get it right. Not that we get it fast, but that we get it right. So we're working on that. If you have input on that, if you have things that you feel strongly about, ban.ingram@ky.gov, and I'd be glad to listen and pass on any of the things that you think about. We want as much input as we can get. The other thing I want to talk about that's not on my slides is Senate Bill 90. So Senate Bill 90 was passed in the last session, and it's a pilot program where 10 counties have been identified, and people with certain charges, some misdemeanors, some D felonies, charges that fall in here that don't have a prior criminal history, they're not violent crimes, they're not sexual crimes, would be, if they want to be, would be assessed within 72 hours of arrest. So this is kind of a post-arrest pre-arraignment kind of a program. If they're assessed to have an SUD and want to go into a treatment program, the charge is held in abeyance. They have up to a year to complete the steps that are put in place for them, which would involve often treatment, well, often residential, but not necessarily, doesn't have to be residential. If they need job skills training, we'll get them that. If they need vocational training, we'll get them that. And the idea is, at the end of this pilot in 3 years, can we show that we get better outcomes from this type of an approach for low-level offenders than we do traditional criminal justice response? We're having a meeting about that just tomorrow. That bill also, Senate Bill 90 also set up a commission or an implementation team to implement the bill. And we're meeting tomorrow at AOC, Administrative Office of the Courts, at 10:30 to start that process. To start the discussions on how we're going to implement this bill. But it's kind of an exciting thing to do something a little different and see how it works out. So I'm chairing that council, the implementation team, and we'll get to work on that in a real serious way tomorrow. The other thing I want to mention is the Opioid Abatement Commission. Many of you may know Kentucky reached a settlement with a number of drug distributors, McKesson, Cardinal Health, AmerisourceBergen, about $480 million. 50% of that goes to directly to local communities. Now, so far, we don't know what communities will be receiving funds and how much each community will receive. That's still being worked on. But then that leaves another 240 million for the Opioid Abatement Commission to grant out. I'm on that commission along with a number of other folks. We've already started our meetings. I think our next meeting is, let me see, I've got it wrote down. It's October 4th at the Attorney General's office on Capitol Drive. So for right now, we're here. You know, the first meeting, I spoke and Dr. Mark spoke about where we're already spending money, just kind of the same thing I've gone over with you. And we have 4 more meetings, but then we're going to travel around the state. In September, we're going to be in Pikeville and Ashland. In October, we're going to be in Hazard and Covington and Lexington. And in November, we're going to be in Louisville and Bowling Green and Paducah. If you go to the Attorney General's website and click on the Opioid Abatement Commission, you can find the information there. Because we want to hear from you. We want to hear from people in the community, your input on how these dollars should be spent. In some communities, it might be transitional housing. On some communities, it might be something else. But we really want to hear from you all, the stakeholders, as what's the best use of these dollars. This is a gift. This is one time. It's a one-time shot of money. So we need to get it right, and we need to spend it wisely, and we need to spend it in a way that complements the other dollars that we have, the federal dollars and the state dollars that we have. And we don't have programs that compete against each other or dollars that work against each other, trying to accomplish the same mission. So be looking for that. It's an exciting opportunity, and come out to those forums. They're from, I think they're from 6 to 8 local time, wherever we are. So people could attend them after work. And please come out and let us know how you feel about that. There's my contact information. I try to leave about 15 minutes for questions. And I'm happy to do that. Janet, have you looked in the chat to see if we got anything?
Yes, we have had some great questions come in already, so I'll go ahead and start with those. But if you have additional questions, please feel free to add them into the chat box. So the first question is from Melissa Tremblay, and she asks, with possession of fentanyl test strips in Fayette County and many others still criminalized and not supported by the local mayors and police leadership, we are struggling on how to educate best how to navigate a fentanyl contaminated supply of pressed pills, opioids, and stimulants. Is this a priority for current efforts to improve this response?
Yes, we're trying to figure out the best way to respond. And I can't tell you I have that answer yet, but I can tell you we're having those discussions. I think fentanyl test strips are important. I think we've got to make ourselves available of them some way, somehow. And that's on our radar, and it's something we're trying to figure out. But yes, it is very important.
Thank you. I thought I'd start with a really tough one.
Well,
number
it's a good question. It's a very fair question.
It's a great question. Yeah. Number 2 is from Megan Whitehead. She asked, how do we go about expanding QRTs in our community?
I think the best way is to try to get local buy-in. You know, I mean, we put out some grant money for QRTs, but really we have other communities that are doing them without grant money from the state. You know, many of you that have heard me speak have heard me say this many times. We're not going to solve this problem in Frankfort for every community in Kentucky. No more than Washington, D.C. is going to fix our problem for Kentucky. They can help, and we can help. But this addiction crisis is to be fought in one community at a time, and finding those local champions. You know, they've got a QRT team in Clark County that have never received a dime of state money, but they're very active and do a great job through their emergency department, their hospital. So if you can find the right champions in the community, certainly our ASAP dollars can help support that. If you get in contact with your local ASAP group and work with them and see if that's something that they want to support. We would support that at the state level for sure.
Thank you. The next question comes from Stephanie Coy. How do we get signed up for Casey's Law trainings?
We haven't set up the new rounds yet, but if you'll contact Janelle Brewer with Sparks Ministry, it's in Powell County. I think if you Google Janelle or Sparks Ministries in Powell County, she's one of the trainers. The other trainers are Charlotte Weathington and Joan Arlingsmith in Northern Kentucky. Joan Arlinghouse. Said that 3 times real fast. And they're going to be setting those trainings up. They don't have locations and dates yet, but contact Janelle and she can help you with that.
Thank you. Alyssa Tremblay asked an additional question. Getting people IDs, such as birth certificates, are needed for the process, and one of the biggest barriers we face daily to getting people into MOUD treatment and job placement. Is there a funding source available for this assistance?
So I've been in Frankfurt for 18 years, and I've watched 3 other governors try to get this done through the prison system. So when people leave prison, they walk out with a Kentucky ID. That's finally happened in the last year and a half or so. The chamber was part of that project. We had some private donation dollars and some state dollars in an effort that involved the Department of Corrections, Division of Behavioral Health, the Transportation Cabinet. Everybody was involved in it, and it worked. If you want to contact me offline and talk about that and how we did it there and what may be available, you've got my my phone numbers and my email there, and we could talk through that process.
Thank you. Monica Masters asks, I'm a case manager for drug court in Bullitt County. We are hitting major roadblocks with housing for our participants. As soon as subsidized housing property managers find out they are in our program, they deny them. Any advice on how to make headway to get our participants off the street and into safe housing?
I wonder if we've ever had a conversation with those folks and find out why they think that our drug court folks are not worthy of safe, affordable housing. That's terrible. I hate to hear that, but unfortunately, we see that kind of discrimination everywhere. And I don't know if it takes a lawsuit to fix it or what it does, but certainly, I think that needs to be challenged in some way.
G. Roberts asks, is it still called an overdose when someone thinks they have bought a Vicodin, but then they are poisoned by fentanyl?
That's a great question. Really, let's call it what it is. It is a poison. When you've been deceived into thinking you're taking one thing and getting another, and actually we have a Class D felony, which is misrepresentation of a substance. That we passed several years ago. But yeah, I agree with that verbiage. It is a drug poisoning.
Okay, Marcy Timmerman asked, would the Opioid Commission funding be available for youth who are in foster care because of parents' addictions? Prevention options for those youth so they do not continue the cycle.
In the meetings I've had so far, nothing's been off the table. So keep an eye on that website. Come out to one of those places I mentioned. So this program is run out of the Office of the Attorney General. A gentleman by the name of Brian Hubbard is the director of this project. Very fine man. He hopes that we're have a portal open to start taking grant applications by November. We may or not make that deadline. I've been in state government a long time. We don't always make our deadline, but that's the goal, to start having a process where people can start apply and make their case for this funding. So, yeah, I don't think that's off the table at all.
Thank you. There have been a lot of comments about housing issues, the ability to find housing for participants that have, or clients that have drug charges. Marcy Timmerman asked, any chance of creating legislation making participating in drug court a house protection?
I don't know. I've never thought about it. I'm certainly willing to take a look at it. It's difficult to be able to tell somebody what they can or can't do with their own property. But certainly we need more transitional housing. We need more housing that'll be friendly to our folks that are in recovery or criminal justice involved. And it's something that we'll continue to work on. We spent a lot of money on it, I can tell you that, but obviously it's not enough. I do know that the Governor's Office for Local Development are putting out a number of grants to support transitional sober housing. I don't remember off the top of my head where all those dollars are going. I know Ashland was a recipient. I think maybe Bullitt County was a recipient. I'm not sure. If anybody's interested and want to contact me, I'll find that list. Or you can go to the Governor's Office of Local Development website, and there may be an announcement there. But they were the recipient of some HUD dollars that were set aside for this very purpose. And they'll have another round of funding in the next fiscal year, which the federal fiscal year will start October 1. So they'll have another round of funding to support transitional housing projects in the fall. So keep your eyes open for that.
Thank you. Another question has come in. Terry Garrett asked, when do you think, I hope I say this right, the 1115 waiver will be enacted?
That's a great question. We wrote that thing in 2020 and submitted it. We submitted it in December, I believe, of 2020. So we had Medicaid and myself and Department of Corrections had every Friday afternoon Zoom meetings throughout COVID on writing that waiver. And we submitted it. Of course, the administration's changed. So we had new people now going into these places in the high-level positions other than the people we were working with. Recently, they have recontacted Medicaid and asked some more questions, which is a good sign. It means somebody's thinking about it. But I think the delay is kind of like what's taken us so long with Recovery Ready Communities, is they're trying to make sure they get it right, because they know if they grant Kentucky a waiver, 30 or 40 other states are going to write for a waiver. So if I try to tell you things, it should be a guess. I just don't know. But we hope, and we cross our fingers, and we talk about it all the time, but we're waiting on that call.
Thank you. Jessica Embry asks, is there any update on House Bill 7 that created the Recovery Ready Kentucky Committee?
That's what I was talking about earlier, Recovery Ready Communities. So as I mentioned, we contracted with VOA Mid-States to help us develop that and then go out to communities and actually implement the program. We'll have our first draft of what the rules are, what the guidelines are, late September. And we hope to be fully implemented by January of 23. So about 5 months from now, hopefully we'll be ready to take applications from communities who feel like they're recovery ready. And it's amazing. I mean, there's no financial incentive to do this. Yet mayors and county judge executives all across Kentucky want to do it, and they're interested in, and they're saying, "Man, when can we do this?" And there's no reason for them to do it except they care about their communities and they care about people in recovery and they want to do the right thing. It's really, really been exciting to see how much interest there is in this program. Because when we when we were drafting the law and talking about it, I really wondered how many communities are going to want to do this. And I've just been blown away by how much interest there is in it.
Thank you. Jennifer Gully asked, where can we find the schedule for the forums that are scheduled for this fall?
So go to the Attorney General, Office of the Attorney General. There, and I think on the left side, there's something about the Opioid Abatement Commission. If the dates aren't and locations aren't posted there, they will be sued. I know that's the intent, is to post everything on that website. I don't know that it's there yet. I just got the email with the locations and stuff yesterday.
Thank you. I was getting ready to post it, and I see that Chase beat me to it. So he did put the web address for that that site in the chat.
Chase is all over it.
Yeah. So that is all the outstanding questions that have been added to the chat box. We have another minute or two if there's anything else you'd like to add, Mr. Ingram.
Again, you know, we're in a mess. I mean, I hate to be a Debbie Downer, but my God, this fentanyl is killing us. It's killing our country. I mean, we had 107,000 overdoses in this country in 2021, more than any other year. And as I mentioned, 2,255 of them were here in Kentucky. And it's the majority factor is fentanyl. That's the common denominator. And it's not like anybody saying, hey, here's some fentanyl. Here's a Perk 30. Here's a Xanax bar. It's in your methamphetamine now. It's in your cocaine now. I was in DC at a briefing 2 weeks ago, and most of all of this is one cartel. It's the Sonoma cartel is carrying the majority of this fentanyl garbage. I hope smarter people than me can figure out a way to stop them. The Chinese and India continue to supply the cartels with chemicals, the precursors to create this garbage. In the early stages of fentanyl, the dark web was most of where it came from. It was being shipped by the Postal Service, by UPS, by the other third-party carriers. And a lot of it was being produced in China. And now that's kind of flipped. The carriers have gotten better at identifying and weeding out those programs. So the business model has switched, and they're just supplying chemicals and precursors to the cartels, who then often get the kids smuggle the chemicals across, so because they can separate them, right? Not have them all in the same transportation conveyance, and then take it all to a safe house somewhere in the United States, but close to the southern border, Texas, Arizona, California. Create the stuff in a house they've rented or leased or bought, and just use their tremendous logistics power to move it across the country. So this is not going anywhere. As I said earlier, they're making bank, and they're not going to stop. So we've got. I'm trying to figure out ways that we can better reach people. I know you're giving out a lot of Narcan and a lot of outreach in your SSPs, but we got to do more. So I'm looking at the criminal justice of folks leaving jails and prisons and figuring out a way to pay for Narcan. Because the vulnerable folks that may themselves or may be around people who are using drugs. So if you got any ideas, I'm glad to listen, because I'm struggling here trying to figure out better ways of connecting with the population that's using drugs and educating and doing anything we can to protect against death. Nobody has ever got in recovery has ever died before. They stayed alive. So in my mind, that's what we got to do. We got to keep people alive until they can get into treatment and get into recovery. And Narcan is one of the great tools we have to do that. That and information. So yeah, we got to do more. We talk about Dr. Marks and I and Dr. Brunfield and I and Dr. White talk all the time about how can we do better? How can we do better? And we're brainstorming, but if you've got some ideas, I'm glad to hear them.
Thank you. Two additional questions came in, and since we have 5 minutes left, I'm going to throw them up here. Dr. John Bingham asked, how do you ensure that chronic pain patients continue to get the treatment they need, particularly for patients cut off by closing pain clinics? Well,
we still, as of right now, there's about 40 very legitimate, very well-run pain clinics in Kentucky. They're not running trailers and they're not running strip malls. They're legitimate medical facilities owned by physicians or hospitals. There's nothing in any law that we've ever written to prevent anyone from getting a prescription for what they need. And I've had 2 knee surgeries in the last few years and walked out with way more than I ever wanted. There's still plenty of prescriptions being written.
Thank you. And the last question that we have is Michael Howard. I work in broad community health. What are some first steps I can take to work with the state to make progress?
Contact me, contact Dr. White. Any ideas you have, anything we can help you with, we're glad to listen, glad to talk. We support outreach and then we want to be a good partners to our local communities.
All right, I want to thank everyone for participation today. Thank you, Van Ingram, for this great presentation and discussion that followed. This concludes breakout session 2A. So up next, we will have a 15-minute break, which will be followed by today's closing keynote, the Kentucky Opioid Response Effort, Harm Reduction Principles and Strategies. Please visit the CE Central website, which I have listed in the chat, in order to get the link to the main session. Yes.
I just want to throw a shout out to my predecessor, Chief Mike Palmer in Maysville, Kentucky. Keep up the good work, Mike. You're doing a great job.
All right. Thank you. Hope you all enjoy the rest of the summit.